We've all been there, right? You give the injection, you wait a bit, and then you ask the patient how they're doing. They tap their chin and say, "Yep, totally numb." But is it really? Today, in this explainer, we're unpacking a clinical mystery that has literally tripped up practically every practitioner at some point. If you're a focused learner trying to map out the biological realities behind everyday clinical practice, well, you are in the perfect place. We're going to look at an assumption that seems entirely logical on the surface, but actually holds a pretty sneaky trap. It's the ultimate clinical question, isn't it? Does a numb lip actually guarantee a numb tooth? For decades, this has kind of been the working assumption in everyday practice. You administer the anesthetic, wait a few minutes, ask the patient how their lip feels, and if they report that thick, tingly, profoundly numb sensation, you assume you've got the green light to go ahead. It makes perfect intuitive sense, right? Like, if the major nerve pathway is blocked enough to numb the outside tissue, surely the inside of the tooth is ready to go.
Well, no, it absolutely does not. This is a massive myth. Lip numbness really only confirms soft tissue anesthesia. It just means the nerve supplying the lip is anesthetized, not necessarily the tooth pulp itself. So the absolute crucial takeaway here is that a numb lip is just one piece of the puzzle, and frankly, it's the least reliable indicator of whether or not your patient is actually going to feel pain when you pick up the drill.
Okay, let's dive right into section 1, the false sense of security.
When you rely solely on what the soft tissue is doing, you fall right into a psychological trap. Let's look at the classic inferior alveolar nerve block, or IANB. The lower lip feels totally numb, the patient reports a complete loss of sensation. As the operator, you check off your mental boxes, assume success, grab the handpiece, you start, and bam, the patient jumps out of the chair. The tooth still responds to pain. How is this even possible when the patient literally cannot feel their own lip? Well, let's look closer at the biology.
Which brings us to section 2, soft tissue versus pulpal nerves.
To really grasp why this discrepancy happens, we have to look at the biological culprits, which are the nerve fibers themselves. See, soft tissue sensory fibers are relatively easy targets. They're blocked early and quite easily by anesthetic solutions. But deeper pulpal nerve fibers, they behave entirely differently. Biologically, because they're positioned deeper and are structurally distinct, they just require much more time to become fully blocked. Or they might require a larger volume of anesthetic to hit that exact same level of profound numbness. Because the soft tissue surrenders first, the lip goes numb super quickly, and that gives us the false illusion that the deeper pulpal fibers have also been blocked, when in reality, they might still be fully awake and transmitting pain signals.
Moving right along to section 3, the accessory nerve problem.
So it's not just about nerve fiber types. We also have to deal with hidden anatomical complexities. As our source notes, the Mylohyoid, or other accessory nerves, can actually continue supplying the tooth despite lip numbness. Think of it like a sneaky biological backup generator. Even if you deliver a totally flawless main block and the primary pathway is entirely shut down, an accessory nerve like the mylohyoid can sneak in through a back door and keep supplying sensation to the tooth. The lip is numb because the main power is cut, sure, but the tooth is still running on that backup generator, receiving live pain signals.
And this brilliantly illustrates section 4, the hot tooth challenge.
Now, even if you perfectly account for fiber types and accessory nerves, an inflamed hot tooth completely changes the rules of the game. When a tooth is highly inflamed, the local tissue environment changes drastically. Specifically, the pH level drops. Biologically, this acidic environment prevents the anesthetic molecules from effectively crossing the nerve membrane. It's a process sometimes called ion trapping. So while the healthy soft tissue of the lip numbs right up without an issue, the inflamed pulpal tissue inside the tooth aggressively fights off the anesthetic. It remains agonizingly painful, completely resisting the block.
So how do we fix this? Let's go to section 5, testing for true anesthesia. How do we break free from this false sense of security? Having seen all these anatomical and inflammatory hurdles, we literally must abandon lip sensation as our primary indicator of success. To confirm true pulpal anesthesia, the data points to objective tooth-specific methods. First up, cold testing. Applying a cold stimulus directly to the tooth tells you instantly if those deep fibers are still active. Second, EPT, or electric pulp testing, which gives you an objective measurement of nerve vitality. And finally, just really careful clinical assessment. Relying on soft tissue alone simply isn't supported by the biological facts.
Which brings us to our final thought. The evidence we've covered in this explainer today fundamentally shifts how we should approach patient care. We know soft tissue and pulpal tissue play by totally different rules. We know about the backdoor pathways of accessory nerves and the intense chemical resistance of hot teeth. So, the next time you're in the clinic and your patient confidently tells you their lip is completely numb, what are you going to test next? Thanks for joining me. Keep questioning those assumptions and keep learning.